Thank you, and thanks to the National Health Council for inviting me to speak today. So from the insurer's perspective, I think what we'd like to talk about now that we've got legal certainty, which has been hanging over our heads for a couple of years, is going forward what we're going to do about affordability. The promise of access is really hollow if nobody can afford the access that's been granted or has been expanded. So from a perspective of affordability, the least that I'm thinking about it is what in the Affordable Care Act is driving lack of affordability, and what pre-existed the act or might be made a little worse by the act that we can address. So there's a few things I'd like to touch on. First, there's a $70 billion premium tax. So this is, going to get passed through. This is, something that those who, get coverage or have coverage will wind up paying for one way or another, including those on public programs, including those who have private coverage. That's a big increase for folks to suck up. That's one. Two essential health benefits. The way that it's being discussed and implemented will require a buy-up in coverage compared to what folks have now. So if you look at what the minimum actuarial value is for the different metal levels and what's going to count as minimum essential coverage, that's going to be a richer benefit package than some folks have. And so that's going to wind up affecting affordability as well. Not to say that those are not the right benefits, the right set of level benefits at every metal range, but to be aware that richer benefit packages simply cost that pool of folks more money. There's potential ways to address that as well. I think the biggest sleeper, ones that folks haven't really focused on that would be very useful to focus on, are the age rating bands. So January 1st, 2014, the age rating band is going to go by law from whatever it is in each individual state as 5 to 1, 7 to 1, to 3 to 1. That's a big change. And so for those who, talking to 150 health policy experts, most of you I'm sure know what this is, but for those who haven't followed this closely, it's the differential between the least expensive in the policy and what you can charge as a premium for those who are most expensive. So if you compress from 7 to 1 to 3 to 1 overnight, the folks who are paying relatively little, the relatively young and healthy, are going to get a very big premium increase. That's going to be a shock. And I think that needs to be addressed to encourage access and affordability. And it leads to the last point. We now know the personal coverage responsibility provision is legal. But we know it's legal because it's not actually, according to the court, a mandate. It's a choice. It's a choice to pay a penalty or get covered. If you choose to pay the penalty, it then turns into, is the penalty likely to induce those who would otherwise not be covered to get covered? The way the economics work it out, the answer to that question for a lot of folks is no. And if you've got folks who are deciding not to get covered and you've got guaranteed issue, you've got the same set of concerns over adverse selection that you did before the law was enacted and as we're existing now between 2014. I think that needs to be addressed if we're going to talk about affordability, because the same adverse selection death spiral that could happen, with guaranteed issue. This is for those who are interested in this. We wrote a brief to the Supreme Court on severability, explaining this, and part of our argument was cataloging what happened in the 7 states that tried market reforms without getting everybody covered, without getting everybody in, and it was universally a disaster, not workable, for different reasons in different states because there were different environments. But if you have a guaranteed issue and you don't have a balanced risk pool, it selects down and just gets more expensive. Only those who are need the coverage, those who have a higher incidence of illness and burden, are the ones who choose to get insured. And if you think about what insurance is, the average cost of care for that risk pool. The risk pool simply gets more and more expensive and less affordable. Those who don't need the coverage as badly or are willing to take the risk of not getting ill that year will choose not to get covered, and it's a bad situation that spirals down. That's still a threat, and that needs to be addressed as well. So the Affordable Care Act has several provisions, I think, that need to be worked on, perhaps legislatively, some perhaps through regulation or other means to address the question of affordability. So that's one. But putting that aside, Bob talked about this in unsustainable, I don't know if he used unsustainable, but there's been a rise in medical costs that needs to be addressed as well. This has been going on for a long time, at least since the mid-90s, pretty steadily. There's been a leveling lately related to, perhaps a lot of things, the economy and others. But it really is a threat to the long-term fiscal stability of the public programs as well as private insurance. I used to work in the antitrust division, so my perspective in coming out this, at least partially, is market power. Driving premiums, at least partially, is provider market power. Year after year, increase that can't be explained by anything else. If you look at Martha Coakley's report as to what's driving premiums in eastern Massachusetts, that's a nice synopsis of what's going on in other parts of the country as well. It doesn't explain everything, but it explains, I think, some areas, and it explains a lot. Market power issue is going to need to be addressed. I think as far as the Affordable Care Act goes, where it's going to be most acute or most important to look at is in the ACO program. So the ACO program, I think, for a lot of the folks that you represent, has a potential for a big upside in terms of care coordination, benefits to patients. Bob mentioned, medical homes. It's not the only way to go about this, but it is one way. All that is really threatened. The benefits are threatened if the ACO program itself induces horizontal and vertical coordination past where it needs to aggregate market power. So the program itself is obviously public funds, and those are set administratively. But the way that they've been set up, they've been encouraged to be attractive to private insurers as well. And the issue of cost shift, again, that Bob mentioned, is a very, very real one. So if you're able to show savings in the public programs and simply take the market power that you've accumulated and raise prices on the private sector, you've really not done what you've promised to do in terms of cost savings and in terms of potential patient benefits. So those are some of the things I think we'll need to be looking at going forward. For those who are particularly interested in the ACO program, I'd want to emphasize this is not new. So there's a lot of this that's going on in the private sector. There's a lot of experimentation. Two of my colleagues, Carmela Bucchino and Aparna Higgins, published an article in Health Affairs that catalogs some of the experimentation around the country that plans have been putting forward in terms of a wide range of care coordination models, ranging from medical homes. There's actually one in our area. Care First Blue Cross started one January 1st of last year that's shown some initial success. There's been some news reports. Aetna and Carillion in Western Virginia have paired up. The Kaiser model, Geisinger model has been long-standing. These are all various ways to do care coordination. And just as a slight aside, my hope for the ACO program is that it will, continue to permit the kind of experimentation that I think we need to find out what actually works and not turn into a one-size-fits-all model. So with that, I'll stop, and after Sonia speaks, be happy to take your questions. Thanks.